Well, ladies, gentlemen, and everyone, a warm welcome to this Wolper Wellbeing Forum on better sleep. And it's hosted by Wolper Jewish Hospital and the Friends of Wolper. And our partner for this webinar this evening is the Sleep Health Foundation. Let me begin by acknowledging the traditional owners on the land from which we're broadcasting tonight, which is the land of the Gadigal people of the Eora Nation. And I'd like to pay our respects to elders past and present. I'm actually coming to you from the land of the Kaurna people in Adelaide, and we may have someone from the Wurundjeri people in Melbourne, and we're from all over the place this evening, but welcome to all. If you haven't joined us before, Wolper Jewish Hospital provides rehabilitation, medical and palliative care to everyone in our community within a framework of Jewish values and religious and dietary requirements. And before we begin our sleep webinar tonight, it gives me great pleasure to introduce Ruth Guth, who's the Community Partnership Officer at Wolper Jewish Hospital, who'd like to say a few words. Welcome to you, Ruth.
Thank you, Julie. We felt that we couldn't just start this webinar in the way that we usually do, because these are not usual times. We're devastated about what's happening in Israel, and we're also devastated about what's happening to the Jewish communities all over the world, and also here in Sydney. So we feel it's appropriate to say a prayer for the safety and well-being of the soldiers of Israel, the IDF, the Israel Defense Force, and for the 239 hostages who are in Gaza. They need all the help they can get. And if by reading this prayer, it helps them in some way, then that's a really good thing. So I'm going to read Tehillim, which is Psalms chapter 20. I'll read it first in Hebrew, and then I'll read the English so that you know what I'm saying. Lamenaseach Mizmor David. Yancha Adonai b'yom tzara yezagevha Shem Elohei Yaakov. Yishlach ezracha mikodesh u'mitzion yisadeka. Yizkor kol minchotecha v'yolatacha yedashne sela. Yiten lecha chilvavecha v'chol atzatacha yamale. Naranana b'shuateha u'v'shem Eloheinu nidgol yamale Adonai kol mishalotecha. Ata yadati ki hoshia Adonai mashicho yanehu mishmek kodsho bigvurot yesha yamino. Ele varechev ve'ele vasusim v'nachnu b'shem Adonai Eloheinu naskir. Hema karu v'naflu v'nachnu kamanu v'nitodad. Adonai Hoshea HaMelech Yonenu V'Yom Karenu. For the conductor, a song of David. May the Lord answer you on a day of distress. May the name of the God of Jacob fortify you. May he send your aid from his sanctuary, and may he support you from Zion. May he remember all your meal offerings, and may he accept your fat burnt offerings forever. May he give you as your heart desires, and may he fulfill all your counsel. Let us sing praises for your salvation, and let us assemble in the name of our God. May the Lord fulfill all your requests. Now I know that the Lord saved his anointed. He answered him from his holy heavens, with the mighty acts of salvation from his right hand. These trust in chariots and these in horses, but we mention the name of the Lord our God. They kneel and fall, but we rise and gain strength. Lord, save us. May the King answer us on the day we call. Thank you.
Thank you very much, Ruth. And if you've just joined us, we're just before we open our sleep webinar, we're just acknowledging the events in Israel. And could I say, as someone who in the last 5 years has visited Israel twice with the New South Wales Jewish Board of Deputies and had the opportunity to visit communities in southern Israel, including Sderot and places very close to Gaza, I'd just like to express as a non-Jewish woman, my horror and distress at the appalling events of October 7, and of course, as Ruth has said, the taking of the hostages. It was clearly a 21st century pogrom and an abomination. And I'd just like to express my deep empathy with the Jewish people at this very difficult time, and also with all the families and individuals who've been affected. So thank you. That's a little bit unusual for us, but obviously these are difficult times. It gives me great pleasure now to welcome everyone. We've had some more people joining us during the prayer from Ruth. Welcome to this webinar on better sleep. And just before I introduce our representative from the Sleep Health Foundation and our panel, just a little bit of housekeeping. You're welcome to ask questions about sleep right from now. You just put them in the Q&A, and we are going to answer as many of those questions as possible. We've actually had sent in quite a lot of questions already, but you can write in questions as we go in the Q&A. We have a question monitor, Dr. Lena Safro, a general practitioner, who'll be monitoring the questions, and I will come to her throughout the night to get the questions that you're bringing to us live. Of course, we cannot offer individual medical advice, but we'll answer as many questions as we can. And remember that this webinar is currently being filmed, and it will be available on the Wolper Jewish Hospital website shortly after. So it gives me great pleasure now to welcome Dr. Moira Junger, a psychologist by background and CEO of the Sleep Health Foundation, Australia's leading advocate for healthy sleep. Welcome. That's what we want, healthy sleep. This is deaf sign clapping. Welcome.
Thank you. Thank you very much, Julie. And thank you so much to Ruth and the team for inviting me to have some opening remarks at the start of such an important webinar. The Sleep Health Foundation is a small not-for-profit national organisation that is community-facing, and we're very, very interested in improving people's lives via better sleep. And that includes education, awareness, advocacy. And I think nights like this it's a pleasure to be a partner in an organisation in such a thing, and to be really looking forward to hearing the esteemed panel as well. So we are non-government funded, although we'd love to get government funding. We rely on some small donations, some membership, and some corporate partnerships for us to do our work. And we're very much wanting to have a good tone within the community about not only that sleep's important, and it's important across the lifespan, every person, every corner, from baby through to older age, but not to be too catastrophizing, to be reassuring, and to be understanding the nuance that no one needs to have perfect sleep, although overall to have it as a big part of your health plan and your well-being. So I don't need to say too much more. I think that there's so many wonderful questions ahead and panelists ahead. So I'd like to just open up, and goodbye from me and good luck with the evening.
Thank you so much. Thank you, Moira. And we're really grateful for this partnership, and we'll send out after the webinar to everyone who's registered, not only our survey where we get your feedback, which we rely on in planning our sessions, but also a link to the foundation's, the Sleep Health Foundation's website. Look, just before the panel comes on screen, we have a quick live poll. What this involves is learning a little bit about you, the audience. So Nat, our technical wizard behind the scenes, is going to put up each question. I'll read the question, pause while you answer it, and then we'll give you the answers in real time. So it's a live introduction to our audience. So Nat, can we have the first question, please? Do you have any of the following? Do any of the following interrupt your sleep? Now, this is multiple choice, so you can click more than one. Do you wake in the middle of the night or early morning? Have to get up to use the bathroom? Cannot breathe comfortably? Coughing or snoring loudly? Feeling too hot or too cold? Bad dreams, pain, or another reason? Multiple choice, click as many as affect you. So let's see the answers, Nat, so far. So you can see there, 84% wake in the middle of the night or early morning. 87% have to get up to use the bathroom. 4% cannot breathe comfortably. 14% coughing or snoring loudly. 37% feeling too hot or too cold. 15% bad dreams. 18% pain. And 7% other reason. Thank you. Nat, the second question, please. How often do you have trouble staying awake while performing everyday tasks? And this is just one answer. Always, very often, sometimes, rarely, never. Your answers, please. Okay, Nat, thank you. 2% always, 6% very often, 28% sometimes, 29% rarely, 35% never. Thank you very much. Our next question. These are about sleep problems. What is your main sleep problem? Just one answer, one choice, please. Trouble falling asleep and or staying asleep. Sleeping for at least 5 hours or more, but never waking up feeling refreshed. A mixture of these problems. Your answer, please. Thanks, Nat. So, trouble falling asleep and or staying asleep, 37%. Sleeping for at least 5 hours or more, but never waking up feeling refreshed, 14%. A mixture of these problems, 49%. Thank you very much. Our next one, please. Waking in the night. How often do you wake in the night? Just one choice. Never, less than once a month, about once a month, two to four times a month, many times a week, daily. Thank you, Nat. So how often do you wake in the night? Never is 2%, less than once a month, 1%, about once a month, none, 2 or 4 times a month, 4%, many times a week, 30%, daily, 64%. This is so interesting. Thank you so much. Our next one, please. Do you have trouble waking up in the morning? Just one answer, please. Always, sometimes, rarely, never. Thank you. Our answer, Nat. So trouble waking, always 7%, sometimes 25%, rarely 32%, never 36%. Now, I think we have some more questions, and you pop one up, Nat, if we do. How long does it take you to fall asleep? One choice, please. As soon as I close my eyes, within 15 minutes, within 30 minutes, within an hour, it can take hours. Your answer, please. Thank you. So how long? As soon as I close my eyes, 10%, and I know we're all hugging those people and wishing we were you. Within 15 minutes, 33%. Within 30 minutes, 23%. Within an hour, 15%. It can take hours, 19%. Thank you. Our next one, please. Gender. Are you male, female, other? Prefer not to say. Thank you, Nat. 29% men, 71% female, and that's our audience tonight. And I think we may have one on age range, Nat. Thank you. Yes, your age, 29 and under, 30 to 49, 50 to 79, 80 and over. And the answers, thanks. So we have 3% of people 30 to 49, 75% 50 to 79, and 22% 80 and over. And so thank you very much to everyone for doing that. And it gives me great pleasure now, with that extra information about our audience, to introduce our panel. And could I welcome onto the screen Professor Ron Grunstein, AM, Professor of Sleep Medicine, Professor Gerard Kennedy, Professor of Psychology, and Dr. Michelle Donegan, who's a dentist and a specialist in sleep medicine. I'll give a fuller interview when you join me on screen. So welcome to you all. I can't see everybody at this point. Nat, are you able to make it possible for me to see everybody on screen, if that's okay? I will be coming to Dr. Ron Grunstein first, if that is helpful.
You can just change your view to gallery view.
Thank you very much. It's nice to have a brains trust. If only you were with me in my general life. Thank you so much. Welcome to everybody, and welcome to everybody who's joined us. Thank you for being such a large number of people. Remember, we can't see or hear you, but your questions are welcome right now in the Q&A. Look, can I come to you, Professor Ron Grunstein, AM first, Professor of Sleep Medicine and Head of Sleep and Circadian Research Group that is associated with Macquarie University, and also a Senior Principal Research Fellow with the NHMRC. And also, tell me the institute, Ron, if you could turn on your microphone that you're associated with. I've forgotten to write it down.
I work at the Woolcock Institute and Royal Prince Alfred Hospital. So,
thank you so much. And if you're able to look up into the camera, yeah, hi. Thank you for joining us. Look, obviously, we want to get a sense of the key problems that people face with sleep and what they can do about it. And as I understand it, when we've spoken earlier, it's useful to think about insomnia, sleep apnea, and other disorders of sleepiness. But what is your first fundamental message? Because we've got a lot of people having trouble with sleep watching us. Reassurance and hope is the core of what you're on about. Is that correct?
I think, Ruth set the scene a little bit in the beginning by we live in very unusual times. And at times like this, people's sleep is often affected, as it was during COVID, when everyone kind of wondered whether they were going to end up in hospital or not. But I'm talking about under normal circumstances. One of the issues is that there's a lot of catastrophization about sleep amongst some people, a lot of anxiety that, that their sleep is in some way harming them or killing them. And I have to confess, some of my colleagues are part of the reason for that, because they tend to over sort of emphasize, the hours of sleep and the risks of health problems and dementia and all that sort of thing. So I think I want to start by saying to the audience, take it easy, that all of us have sleep problems some of the time. Well, we don't always be satisfied with sleep. Sometimes we try too hard to sleep. And, the main thing is to identify specific sleep disorders and what we can do for those people.
Thank you. Well, can you run us through what you see as key sleep disorders and what the current treatment is, but what the hope for the future is in terms of new options, particularly around medication?
Well, the commonest sleep disorder is insomnia, which, may manifest as difficulty initiating sleep or maintaining sleep, or both, or, waking up unrefreshed despite apparently having normal hours of sleep. So insomnia is a bit of a Cinderella area in a sense, because we still don't know enough about, what determines whether someone gets insomnia. Most people have a problem with what's called hyperarousal. The brains are too switched on. Also, their propensity to sort of wake up we have this concept that's important to get, is that the brain is not uniformly in the same state. So the brain can be both parts of it awake, parts of it asleep. And what we're beginning to understand about insomnia is that, you know, people with insomnia have more parts of the brain awake, and that's why they perceive often that their sleep is poor. But then lots of parts of their brain are getting sleep. So, you know, it's a very curious situation. Yeah, some animals are like that, where, you know, one half of their brain sleeps while the other half is awake. Dolphins, for example. So, you know, that's insomnia. In terms of treatment, I think Gerard will talk, I'm sure, about behavioural management of insomnia, which is critical. But these days, we're moving into a different generation of medications for sleep. So in the old days, the standard was what was called benzodiazepines or benzodiazepine-like medications. So Normoson, Stilnox, so forth. They had side effects in terms of the risk of sometimes addiction, but also a risk of sort of waking up quite groggy and so forth. These days, there are new medications which are called orexin antagonists. I've got to introduce orexin here because orexin is a brain chemical that stabilizes sleep, keeps people awake. So if you stimulate orexin, you're more awake. If you block it, you'll promote sleep. So these are blockers of orexin.
And they're available now.
They're available now, but, you know, they're not things that the government necessarily, you know, subsidise or anything like that. So there is an expense, but there are two of those available in Australia. But again, I just want to reiterate that the behavioural management of insomnia is critical. You need to be a bit judicious about who you have on medication.
Could I just ask you
yeah.
quickly there? My late mother, because I noticed we have an older audience here with us this evening, and her medical practitioners were very hesitant to give her any medication to help her sleep because of fear of falls. And just this orexin inhibitors, are they less likely to make you at risk of falling?
Yeah, that's one of their advantages. They don't sort of cause the grogginess and sort of balance problems that sometimes people get in the middle of the night. So it's a lot safer to wake up in the middle of the night and go to the toilet with those medications, for example. They're not perfect, you know, they do sometimes people are sleeping in the morning on the medications and so forth. But the addictive risk is much lower. And in fact, these drugs are now being used in the management of addiction disorders. It's a long story, but you know, it's another story that maybe not right for now.
Before you go on to just a definition of insomnia.
Well, I mean, I think you know, if you ask a person, that everyone's got a slightly different. You know, it depends what their expectation of sleep is. But you know, in a sense, it's a subjective phenomenon. There's not like a clear test that says you've got insomnia and you don't. If you feel that you're not getting enough sleep, or that you can't get off to sleep quickly enough, or it bothers you that you wake up in the middle of the night and have trouble getting back to sleep, or you wake up unrefreshed, that's insomnia. When it's, you know, what the issues, everyone gets acute insomnia under stress or whatever, but it's the chronicity that is often quite important.
Well, we just hear about sleep apnea. I thought I'd give you a basic introduction before we go to our first questions, and a reminder, we do have Professor Gerard Kennedy, who will be looking at the psychological issues that in a sense have been referred to there by Professor Grunstein. But tell us about, you know, what is sleep apnea, the current treatments, and your thoughts there.
Okay, so sleep apnea is really a disorder which is characterised by snoring and pauses in breathing, and the main daytime consequence is excessive daytime sleepiness. So this common problem is that the airway collapses during sleep intermittently, and that causes an awakening and fragmentation or disruption of sleep, and so you end up with poorer quality sleep, and therefore you're sleeping sort of during the day. It can be extreme. People can stop breathing, 50 to 100 times an hour in the most extreme cases. But it typically is characterised by loud snoring, sometimes very loud. In terms of management, I think most people would be familiar with the continuous positive airway pressure machine, a mask and a machine that actually takes air from the room and pressurizes it and keeps the airway open as it delivers the air through a mask, into the airway. And that was invented in Australia in the early 80s and is now the main treatment of moderate to severe sleep apnea. Problems with it is you've got to wear it for it to work, and not everyone likes to do that. And it can be quite intrusive. People worry about it. So we've always been looking for other treatments. So my research career has been focused on what else can we do. So there's a number of treatments. I mean, Michelle will talk about the mandibular advancement split, the dental device that actually keeps the airway open by typically moving the bottom jaw forward. We're exploring medications, and I think the biggest hope and the medications that will revolutionise the treatment of sleep apnea over the next 5 years are what are called, the current new name is nutrient stimulated hormones, but this is the Ozempic, Wegovy, Mounjaro, those newer drugs that cause people to lose a lot of weight. The reason for that is about 70% of the sort of cause of sleep apnea is people being overweight or even obese. So if you can do something significant about your weight, as these drugs do, which previous drugs never were able to do, you are going to reduce the severity of sleep apnea and sometimes even cure people. We're currently doing a trial together with a number of other countries where we're looking at these medications to see how much of sleep apnea will they get rid of. And those results will be through probably May, June next year.
That's amazing. And could I just ask you, as well as the medications and the devices, and we will hear from our sleep medicine dentist later in the session, is that core advice of exercising more and losing weight, which seems to be the advice of every session we have at a Wolper Wellbeing Forum, if you can exercise more and lose weight, if you're able to, can that reduce your sleep apnea?
Well, I think you've got to step back and say exercise, what you eat in your diet influences so much. I mean, one of the biggest problems in the world is the increasing rate of diabetes. So that is, ingrained in exercise helps that, diet helps that. The reality is that until now, we've never really had a reliable way to lose significant amounts of weight, unless you had what's called bariatric surgery, gastric bypass, and those sort of operations. Now, some of these medications get results that match the surgery. So, there's problems with it. Sometimes there's a slight more rate of side effects and so forth, but, they are very effective, and they do something that the mask treatment doesn't do, which is to fix the risk of diabetes, lower blood sugar, lower blood lipids, and lower blood pressure. And so we're now entering this phase where, I spent my career putting masks on people's faces and machines, and now a lot of us are, realising that in the next 5 years we're going to be changing our approach.
Look, I'm going to come to our first questions in a moment, but just to clarify there, that those new medications involved with a trial involving assistance with weight loss, they're not currently being prescribed for that purpose? Is that something that's on the horizon rather than a current option?
Currently, they're being prescribed when you can get them for diabetes, either prevention or actually for the treatment of diabetes. They're remarkable in that effect. But you can argue that obesity leads to diabetes in many cases, so therefore they should be available for the treatment of obesity where there's a diabetic risk. So, but at the moment, as you know, there's a shortage. They can't make it fast enough. So when that problem goes and the price comes down as more players enter the market. That's why I said 5 years rather than next week. You know, you'll see a change in the way we approach things.
Look, thank you so much, Professor Ron Grunstein, our Professor of Sleep Medicine. I'd like to invite now Dr. Lena Safra, our General Practitioner, who's monitoring your questions and also saw the questions that people sent in advance. Lena, can you join us and give us a question, please?
Yes, hello everyone. So we've got quite a few questions on medications which are being commonly prescribed in general practice for insomnia. One of them is Stilnox. And so I've got two questions about Stilnox. Should it be stopped after 20 years of use? And also, should older people over 80 worry about a risk of addiction?
Professor Grunstein, I'll come to you, please.
Sorry, I muted. The first question related to someone who was on Stilnox for 20 years. And I've been asked a question quite often by people who've been on Stilnox for maybe not that long, but 10, 15 years. Look, the reality is that if you're on a sort of normal dose and it's working for you, you may argue that it's probably not the smartest thing to stop someone because, you know, there would be risks of withdrawal, possibly, although maybe not. I think there's been a lot written about the risks of, say, increasing dementia by this whole class of medications. But interestingly, big studies now done in places like Denmark and thousands of people have not found that to be the case. So, you know, I would be, as a clinician, I'd be kind of reluctant to tell someone who'd been on Stilnox for 20 years to stop. Obviously, if someone starts Stilnox and gets all sorts of any side effects, then yeah, you don't go on with it. But you've got to be smart sometimes and not try and rock the boat too much. And sorry, the second question was
Relating to should there be concerns about addiction, I think, Lena, after a long period of time, particularly with older people. Yeah,
look, I mean, there are a lot of studies now longer term with hypnotic medications, you know, a year. People have looked at intermittent use and found that really it's not much different in outcomes between intermittent use, like maybe 3 times a week or twice a week compared to every night. So I think the addiction risk is more when people escalate the dose, you know, when you suddenly see someone coming in who takes 10 Normoson every night, you kind of say, well, that's a problem. You need to do something about it, and you need to see sometimes an addiction specialist. But, you know, withdrawal is a big problem. But for most people, taking it, if they don't have any adverse effects and it works for them, is important. But I go back to what I said before, and Gerard can expand on this, is that the critical thing for most people is the behavioural management of insomnia, that you reserve the medications for those who really have run out of alternatives in terms of behavioural treatments. And I will come to you, Gerard, shortly, but let's just take one more question, if I may, Lena, from our audience, because we've had so many audience questions in advance.
Sure. So still on the medications, there is a question about cannabinoid oil, the CBD, and its effect on sleep quality.
Okay. What I'm going to say may shock a few people, but basically there's no good evidence that cannabinoids make any difference to insomnia, or at least there's one study which shows a little bit of evidence, and that was for a CBD combination with THC, which is the more psychoactive part of cannabis treatment. We've just completed an acute study looking at a combination of this THC and CBD on sleep, and actually, you know, the results showed that sleep was actually particularly REM sleep, rapid eye movement sleep, was reduced, and there were changes in the brain that weren't really positive to sleep quality. We've also completed a study of CBD alone, which is as a medication orally, and look, the results we're still looking at, but I wouldn't say that they're dramatic and don't convince me personally that CBD is, at least the doses that we used, is going to be an effective treatment for insomnia. You know, it's got to be replicated. But the other point about CBD is that high doses of CBD may be okay, but we don't have evidence for that. And I'm told it's extremely expensive to produce that sort of dosage.
And just unpack CBD one more time for people not familiar with that acronym.
So it's a cannabidiol. It's a non-psychoactive form of cannabis. You know, so the cannabis has a number of different chemicals in it. THC, tetrahydrocannabinol, is the psychoactive form, you know, when you get high, you know. So you can balance the two. You don't have to get high with a medication, but it does, you know, I mean, the belief was that it promoted sleep, you know, when you got stoned, you went to sleep and all that sort of stuff, probably after eating half the food in the kitchen. But, you know, the issue is that our experiments looking at this versus placebo shows that you know, it's not the case that these psychoactive versions of cannabis don't help sleep.
And just alcohol and sleep. What's the evidence there? Because, you know, some people think I'll have a couple of nips to get to sleep.
Look, you know, it may get you off to sleep, and it also depends on how much you're drinking. But your sleep is often disturbed, and the quality of your sleep is disturbed. And I guess if you drink a lot, you produce a lot of, you know, urination. People wake up at night, but you know, it's a bit of a poison to sleep, to be honest.
Okay. Yeah, well, that's a great blunt message, a poison to sleep. We will come back, ladies and gentlemen, and everyone, to Professor Grunstein, but I'd like to welcome now Professor Gerard Kennedy, Professor of Psychology at Federation University, a senior clinical psychologist currently with the Bendigo Sleep Lab in Victoria. But Gerard, I must get your name right. It's Gerard, isn't it?
Either Gerard or Gerard.
Yeah, great.
Either's okay. Yep.
I'll stop worrying about it. I beg your pardon. But Gerard's had 24 years previously at the Austin and also 15 years at Monash Medical Centre. So you've had an extraordinary amount of contact with individuals grappling with sleep. And I think that survey at the beginning, could I just ask you for a reaction to that, Gerard? Did that surprise you, the level of sleep troubles that people are dealing with?
No, it doesn't surprise me, and the figures were sort of in agreement with what you'd expect for insomnia, and also maybe what you'd expect for sleep apnea, with some of the people reporting, you know, problems with not breathing well or choking, coughing at night time. So the figures were quite normal. A lot of people have these problems, yeah.
And you know, we're keen, I know, to get practical advice from you. I understand that one key message that to sleep, we need to be low in physical and mental arousal. So what do you mean by that? And how can we be low in mental and physical arousal? What should we not do?
It's pretty much the secret formula for sleep is to be low in mental and physical arousal in the hour or so leading up to bedtime. And that means in the last hour or so before bedtime, people should engage in sort of fairly passive activities and not be, you know, doing their taxes or anything that requires too much thought, not be doing a lot of exercise really late in the evening or cleaning up the house or anything like that. So most people would be watching TV or reading or listening to radio, that type of thing. And also it relates also to your problem solving, like if you've got issues that you want to work out, you know, like people like us, we're always thinking about things, and sometimes it's good to put aside a time earlier in the evening to think through your problems or solve problems or even have worries that you address, because a lot of people make bed the place where they go to think and worry, which is never any good. That leads to higher arousal mentally. We want a fairly peaceful approach to the bedtime. If you can spare an hour or two before bedtime to relax and just unwind physically and mentally, it's a good thing.
And could I ask you, that idea of things being on your mind, any practical tips, like, for example, writing a to-do list for tomorrow an hour before sleep, so you don't take that. So you go.
often if I have a bad night, it's on the weekends, because on Friday, Saturday, I've slacked off, not thinking about work or anything. And then suddenly on Sunday night, I start thinking I've got to do X, Y, and Z, and I haven't got enough time to do it. And so normally I would have written it all down on a piece of paper in a diary on the computer and thought about it well away from bedtime, not just before I go to bed on Sunday night here, or 9 o'clock or 8 o'clock on Sunday night. So it's good to have a planned or controlled session every day where you do some thinking, worrying, and planning. So most of the things that I would do would be thinking or planning. But an example of worry could be just before I go to bed, I might think to myself, gee, mum's getting old because she's living alone. She's 92 years old. And you're thinking something might happen. But I can't do anything about that at 10:30 at night time when I'm about to go to bed. What I should have done was rung up early. Everything all right, mum? Brother's treating you good? Got enough money? And you need anything? Just keep the social connection with her and keep her welfare in mind. So we need to, everyone has worries, and it's usually about people, other people in your life, children, grandparents, mothers and fathers, children, etc.
We opened our session this evening because of the association with Wolper Jewish Hospital. We will have a considerable number of people from the Jewish community watching tonight. And clearly, aside from the normal everyday worries of life, many people watching will have family and close connections in Israel at the moment. So that's an extreme sort of worry, isn't it? Your thoughts there for that particular sort of situation?
That's likely to cause some people to have an acute bout of insomnia because they're worried about this situation that we've got no control over. And we do have ones closer to home, because Australia is prone to various natural disasters, fires, floods, cyclones, that type of thing where people are displaced. I was recently just in the town of Rochester in Victoria that was completely flooded out, and people are still living in caravans and tents in caravan parks in that town, and I'm sure that they've had lots of sleepless nights because of that disruption to their life, and it goes on for a while because it takes governments and other authorities a while to rectify and help them get back to normal living. So, when we have these conflicts abroad and terrorist acts and so on around the place, it does upset people. And not only from the Jewish community, but the general community is upset by those sorts of things as well, because no one likes to see that happen.
And, the 24-hour news cycle, I just want to come, I guess, to both social media and news media in particular. When there's an international situation, you can sometimes watch out of hours. Do you know what I mean? What again is the key to stop doing it at least an hour before you're going to try to go to sleep?
At least I remember when the Twin Towers were down, and I kept watching it, and after a while, I was sort of vicariously traumatized by it because I watched it so many times because it kept popping onto the TV all the time in the next days and weeks after the event. So I made a conscious effort not to watch it anymore, even though it was, like something that was an abhorrent act again. So I think it is good to give yourself a buffer. Like if you're watching news, not to be watching the last news just before you go to bed, because if you see something that plays on your mind, it's going to be hard to shut that off. In the insomnia world, one of the most common problems, as Ron mentioned earlier, was that a common insomnia issue is an overactive mind. People say that they can't turn their mind off when they go to bed. So that's one of the most common things. And these other factors outside yourself in the news and in your life tend to exacerbate the overactive mind, the person that's prone to that.
Yeah. And so what's your tip for the overactive mind? Because that's definitely something that's been raised in our questions.
To make sure you do all your thinking and worrying earlier in the day, and at a time when you can actually do something about the things you can do something about. And then also perhaps to practice some form of relaxation or meditation, whether it be listening to classical music or the music that you like, or following a mindfulness app or a progressive muscular relaxation script or something like that, just when you're lying in bed. So, because actually when you're relaxing in bed, it's actually more chance of falling asleep. You're horizontal, lying in the dark, and you're doing something like breathing, controlled progressive muscular relaxation breathing. If you think about when someone goes to sleep, you can watch them lie down and they start to breathe more slowly, and their muscles relax and they fall asleep. So some of these sort of apps are creating activity that's precursory to sleep anyway, which is a good thing, and occupying the mind a little bit because you're following the script and trying to do exactly what the person tells you in the script. I always say to patients, don't try too hard to relax though, because you can't relax then.
Yes, just before I come to that question about how we think about sleep and our desire to sleep is important, I just want to, you mentioned listening to apps or to music, whatever. Some people listen to the radio all night and it becomes a habit to have that there. Your thoughts on that?
If you're listening to a pure music station like a classical FM station or something like that, it's probably not so bad. But if you're listening to talkback radio, you've got to hear the end of that conversation or the next quiz question in the overnight ABC quiz, on the radio. So sometimes it's not a good idea to listen to that type of ongoing, progressive, conversational type radio at night time when you're in bed. Listen to it before you go to bed and then stop, turn it off and go to bed. And that brings us to the idea that most of us should have a bedroom where all we do is go there to sleep, not watch TV, not play on a computer, not to listen to radios. Because a lot of what we do when we sleep is actually a conditioned response built up over the lifetime. When you've got little kids, they tell you they're not sleepy, you put them in bed, turn the lights off, and 5 minutes later, they're usually asleep, So it's a little bit the same with us. When we enter the bedroom, it's like the conditioning of years of, you go in the bedroom, you fall asleep in bed is there. That having been said, though, that some people develop a reverse conditioning so that when they go into their bedroom, they tend to wake up and start to do all sorts of other things. And they're the ones that might be doing a lot of thinking and other things in the bedroom, reverse conditioning. So our job as a psychologist or behavioural counsellor would be to try to recondition them so that the bed becomes a place that produces the phenomena of sleep in the person.
When I spoke to you earlier, you also offered reassurance, a bit in the manner of Professor Grunstein, in that when we go into that dark space, lie down, slow down our breathing, even that lying in the darkness and resting is going to help us to think of it in a positive way. Tell us about that idea of how we think about sleep and how we can't control it.
Okay, people tend to think of sleep usually as a state that I'm conscious or unconscious, but sleep is also a behaviour, but it's very unlike all my other behaviours. Most other behaviours I can control volitionally. I can make myself talk louder, jump higher, work harder. But the moment I start trying to sleep, it doesn't seem to work. And many of us had the situation where you've got to give a big presentation at a conference or something like that, and you think to yourself, I better get a good night's sleep. Half the people at the sleep conference are probably sleep deprived because they're worried about their presentation the next day. And that's the anxiety that creates is there because you're thinking, I've got to give this presentation, I've got to find my way to the place, get to the stage, get it into the right session, get on the stage, not forget what I've got to say, and you get all worried and stressed by that. But it's only an acute situation. The next night you'll sleep well again like you did before. So we've got to be cognizant of the fact that when people start to become, when you sleep well, you never think about your sleep. It's only when you start to sleep badly, you start to focus on it. And some people become very over-focused on their sleep. And it might be prone to the person that's more anxious in general as well is, when you see people for sleep problems, anxiety about sleep's a big issue. But if they've got an anxiety problem underlying that, it's even harder to help them because they're doubly anxious about everything and then anxious about sleep as well. Yeah.
And do you find you can help those people over time?
Definitely can, but over the years when I've been working in hospitals, other psychologists have come along and said, I'd like to learn about how to treat insomnia, and they soon seem to disappear because they find that the clients with the high anxiety level to treat, because you've got to do a lot of coaching. You've got to talk a lot and go, if you do this and follow that and do this, you'll be right. It's not like if someone's very depressed, I'm going to be more passive in my approach to that person. You can't push someone that's very depressed, but the anxiety sufferer has to be pushed to change their thinking, change their behaviour.
Look, thank you so much. And I'd like to welcome back Dr. Lena Safro, our general practitioner, monitoring your questions. And let's hear some questions. And after that, I'll be coming to our dentist to hear about these other appliances that can be helpful. Lena, thank you.
So we've got quite a few questions about waking up at night multiple times and also waking up very early in the morning. And people would like tips on how to get back to sleep quickly.
Look, what I might do is come to you, Gerard, first, and then also get a comment from Professor Grunstein. Thank you.
Yep, sure. First of all, let me say that it would probably be normal to wake up 2 or 3 times a night. And most of the time, you won't remember it unless you stayed awake for more than about 5 minutes. And I'm in the older group, being about 68, and sometimes I don't wake up at all, but other times I might wake 2, 3 times a night. And most times I don't wake up to go to the toilet, but occasionally I might, So if I wake up 2 or 3 times a night, it's not a problem. The problem becomes an issue when you cannot get back to sleep. And a lot of people would have their best sleep in the first 2 to 3 hours of the night, where you have most of your deep sleep. And then as the night goes by, the drive for sleep drops off. And as we get older, that drive is somewhat weakened because you have less deep sleep anyway. So one tip is a few tips that I usually give to people, and one is what we call stimulus control. That if you don't go back to sleep in a short time, like less than 10, 15 minutes usually, it might be helpful just to get up momentarily and go to another room and then come back again when you feel a bit more relaxed. Some people might say come back when you feel sleepy, but it's a trade-off. If you wait too long, you might wake up more. So it can be good just to get up and come back pretty quickly after 5 minutes, after you've sort of calmed down a little bit. And it's like in your mind, you're trying the night again. Another tip would be to, if you wake up and you had trouble getting back to sleep, to employ some sort of distraction process, like doing relaxation or listening to a mindfulness app or that type of thing in your bed, and trying to think, thoughts that are relaxing, sort of think about things that you'd like to do, maybe planning a trip or that sort of thing, but not too intensely. And as the morning goes on, it gets harder to get back to sleep because the drive for sleep is weakening. We build up a drive over about 16 hours during the day. We execute the drive in the first sort of, probably half of the night, and then the rest of the night it gets a little bit weaker, and towards morning it gets quite difficult to go back to sleep.
Okay, look, thank you. Professor Grunstein, a comment from you about this frequency of waking, and I guess the issue of whether there could be any underlying health issues. If you could turn your mic on, please.
Yeah. I think I just maybe follow what Gerard said, and also to sort of point out that, you've got to look at the overall management of sleep, not just on the one night, but, it is actually quite important to not spend too much time in bed. People tend to respond to a bad night's sleep by sort of going to bed earlier and trying to, lengthen their bedtime. And in fact, that's wrong. You often need to restrict your sleep time to build up what Gerard's talking about, this drive to sleep. So a lot of apps and a lot of the behavioural management is actually talking about short, what they call sleep restriction or bed restriction, trying to reduce the amount of time that you spend in bed to increase the natural drive. The other important thing I think is coming out of research now with large population studies is sleep regularity. The person who sort of one night gets into bed at 8 o'clock, the next night gets into bed at 12. That's an exaggeration, but irregular sleep hours are actually quite harmful to sleep quality. So there's sort of general points. I guess where you're heading, your question is, we say that 30% of people with sleep apnea present with an insomnia-like picture, particularly in women. And therefore, you need to have your sort of radar on for potential signs of sleep apnea, snoring, or if the person's overweight, that sort of thing. And, you may need to investigate that person for sleep apnea to reassure you that that's not part of the reason for frequently waking up at night.
I'd just like to take this opportunity, if I may, to bring in Dr. Michelle Donegan, and thank you for waiting so patiently, Michelle. Michelle is a dentist and a specialist in dental sleep medicine and oral devices, and she shares her expertise with the ADF. Is that the Australian Defence Force?
Correct.
Yeah, fantastic. And also sleep registrars at St Vincent's Hospital, Sydney, general practitioners, and as well as conferences and so on. And you're a fellow of dental sleep medicine, which is a relatively new registration. Can you just tell us a little bit about that, just quickly?
Okay, so dental sleep medicine encompasses the dental treatment of sleep disorder breathing and some of the comorbid features. So that could be snoring, sleep apnea, bruxism, tooth grinding, and temporomandibular joint disorders. However, in the US, the definition includes some elements of oral medicine, treatment of mucosal diseases,
Okay, thank
and
you.
reflux.
Oh, okay. Look, what I wanted to hear about, and it was referred to by Ron Grunstein earlier when he was talking about the CPAP machines, you know, like the mask with the machine that we're aware of. But you're involved in a sort of a less intrusive and easier to comply with mechanism called the mandibular advancement splint, which is all about stabilizing the jaw and opening the airwaves. Can you explain how you would get a referral and then how you'd go about helping a patient and seeing if that splint is a useful idea?
Okay, thank you. So a sleep dentist or somebody with expertise in dental sleep medicine works in a team environment. Some practitioners are in dental practices, some do oral appliances exclusively. And under the referral, it could be also from an ear, nose and throat specialist, or it could involve also sleep psychologist, dietitian. There's a bit of a journey along the way. So ultimately the referral from the physician to the dentist enacts the treatment. And that's, I think, a very important part of it, because sometimes patients do have quite a few things going on in their sleep history that cannot be managed by a sleep dentist. So my role is really just the mandibular advancement splint.
So what is it? What does it look like and how does it help?
Okay, so a mandibular advancement splint, technically known as a device, is two pieces worn in the mouth. So it's an oral appliance on the upper arch and the lower arch. It's smaller than a mouth guard. So patients often perceive this to be a mouth guard, but it's not. So it's a specific type of material, Australian standards, and it is used to stabilize the jaw. And by criteria, it should be adjustable. So there's a period of adaptation and adjustment whereby the patient is able to wear it and comply and hopefully adhere.
Yeah, and that's critical, this compliance issue, isn't it? It's a term used in medicine often, but is it just basically means you use it as often as advised and in the manner advised? Is that what compliance is?
I think we like to use adherence now. So I think previously compliance was the term, but we like to say adherence. So the patient is able to use a therapy and derive benefit from it and continue using on a regular basis. So compliance, I think, is more the element of being told to do something.
Okay, I wasn't aware of that transition in language. And tell us the criteria for patients that are most likely to benefit, because there are some characteristics, aren't there?
Okay, so the patients who, evidence-based research, we have some guidelines in whom we know it works best or might be suitable, and that's the patient with generally a BMI under 30. However, that has crept up recently to 34.95. So the thing about BMI is you can have ladies who are a little bit different distribution of adipose tissue, whereas a man will have a thick neck. So BMI, there's a bit of movement on the BMI with women.
And this is the body mass.
Body mass index, thank you. So mild to moderate apnea, or the lower the apnea, the generally more successful the treatment can be. But in saying that, some severe apnea patients have been treated. It's just that there's a shortage of research on severe apnea patients because of ethical reasons. They're not tested for risk of respiratory failure. So,
I
yeah.
see.
So,
It's too risky to try the smaller device.
yeah. So, but the research is forthcoming. There is more out there. It's just a matter of time before things shift. So we're looking at mild to moderate apnea, LOAS or BMI, no major health comorbidities, lots of health issues, and some anatomical features, dental features like a short square face.
A short square face, because correct me if I'm wrong, and I'm going to come to Professor Grunstein as well in a moment, because I know that have referred people to people with the skills of Michelle, and I'd be interested to know when you would do that. But evidently some people can have a receding jaw or a flat face, and that can cause sleep difficulties. Does your this device assist with that sort of thing?
Yes. So that would be the patient, the smaller jaw. So when you bring that jaw forward, it opens the airway.
Oh.
So for some patients, most human beings have got a range of 12 millimeter average. So when you bring the jaw forward 50 to 60% of that range, 5 or 6 millimeters, that is when the muscles at the posterior of the throat, the airway increases cross-sectional area.
And this is your primary area of work, isn't it? This is what you do.
That's what I do.
Yes. And I love I love having the bed in the background while we're talking about sleep. It's just too good. But could I come again to Professor Ron Grunstein, our Professor of Sleep Medicine? In what sort of situations would you refer a patient to someone who's into dental sleep medicine?
Look, I think, it's a field which has developed pretty fast over the last 10 to 15 years. We did a study, I don't know, quite a while ago, probably when Michelle was in high school, but just stirring her up, if it's okay. But we compared the CPAP machine, the mask, with a dental device, and what was called a crossover study. So everyone got both treatments in random order. And we found there wasn't much difference certainly in the population that we're looking at. So the population we generally look at, as Michelle said, we're not going to be treating people with marked severe obesity. We're not going to be treating people, at least initially, with very severe sleep apnea, very frequent breathing pauses. And of course, when people like the anatomy that Michelle was talking about, it favours these devices, we would send them. The reality is we practice in what's called a interdisciplinary or multidisciplinary sort of setting. So, we will often send a patient, say to Michelle, what do you think, and she may come back and say, yes, no, or maybe, that sort of thing, and then we discuss it. But it's important because there's no hard and fast rules here.
Just say, as a patient, it's called a mandibular advancement splint. And just the names of things can be so confusing for patients, because I've seen pictures that Michelle has sent me, and they look a little bit like mouth guards. Nothing in it makes me think of splint. Can you explain why the word splint is there?
Well, I think that has evolved from general dentistry, and we probably shouldn't call it splint, but more so MAD, mandibular advancement device.
Yeah.
A splint generally is a single arch, like a horseshoe-shaped appliance, like a bite guard, to protect the teeth. And that's all it does, is protect the teeth. It doesn't reduce your apnea. It doesn't reposition your jaw. It just protects the teeth from a patient who's clenching or grinding, from, tooth breakage. So really, we should say mandibular advancement device. We should.
Yeah, I just suggest that because
Sorry.
Oh no, don't apologise. I've actually had a doctor mention it to me myself, and I thought splint, but look, I don't want to take time too much on language. What I'd like to do, if I may now, is to come back to Lena Safro, and let's take some of the questions that the audience have been bringing to us. And thank you for being with us, everybody. Back to you, Lena.
Sure. So there is a question from someone involved in shift work. They want to know if sleeping during the day offers the same quality of sleep as sleeping during the night.
Can I come to Gerard Kennedy first, and then I'll come to Ron Grunstein?
Sure. The general sort of research shows that after someone's done rotational shift work for a number of years, they might have started as an 8-hour sleeper, they end up being a 6-hour sleeper. They still sleep reasonably well, but when you try to sleep during the day, there are all sorts of disturbances in your house, in your neighbourhood, etc. So if you had a good quiet environment, you might get good sleep during the day if you can do that. And we also have different types of people that can adapt to shift work and those that don't really adapt well. The early bird types, the larks or the bakers, don't adapt well. The chefs, the late night people, the owls, they do adapt better to sleep because they can delay their sleep easier, whereas the early type can't delay their sleep well. And that's true of jet lag as well. So we have chronotype, which is clock type in people. So most of us are intermediate. We go to bed 10:30, get up about 7:30 in the mornings, but some people go to bed at 5 in the morning and get up at 12. They're the chefs. And the bakers go to bed at 7 at night time and get up at 3 or 4 to start their baking.
Thank you, Professor Grunstein.
I think agree with Gerard. I think some people are born to do shift work, and some people should never even try it. That's basically it. And we've had cases within industrial sort of litigation about people who said I can't do shifts, like nurses. I can't do night shift because I'm not going to make mistakes. And sort of the government says, well, you've got to work night shift. And I think there's a reality that there are some people who just can't do it. There are sort of aids. I mean, people have shown that there are some ways of keeping people more awake at night. And caffeine is probably the simplest sort of method, but also some medications help in critical industries. I think, sometimes if people have problems sleeping during the day, there is a role for some of these newer hypnotic medications, or even there's some evidence that melatonin may work better during the day when melatonin levels are absolutely zero or very low in order to aid sleep. So I don't think it's a hopeless situation, but I certainly agree with what Gerard says, is that some people are able to do it and other people aren't, or some people are, have great working at night, musicians and chefs and the bakers, get up early and work then.
And could I just ask you about the so-called nana nap for women, an afternoon nap, because we do have an older group here. There'll be quite a lot of people retired. Is that a good idea or a bad idea?
Look, I think it's important to understand with aging or getting older that the amount of sleep that you get may not be the same as when you're younger, and also your sleep can be more fragmented. And so that's a phenomenon. There's a lot of biological explanations for it, but that's the reality. So if you're sleepy during the day and you kind of, nodding off, having a short nap is probably a reasonable thing to do. I don't think long naps, because you often wake up, with what's called sleep inertia. You're sort of in a deep, slow, your brain is slowed down and you suddenly wake up and you wonder where you are. That type of nap may not be that helpful, but short naps, 20 minutes, 30 minutes, as you say, nano naps, they're fine, I think.
Well, thank you so much. Coming back to you, Lena, for another question, please.
Yes, still on the shifting timelines. What's the best way to prevent jet lag and the best way to manage it?
Ron Grunstein? Yeah, thank you.
I've always answered this question when I'm asked by a radio person, but basically the best way to avoid jet lag is to fly first class. But that's not within most people's budgets. So
that's right.
I think there's certain things that you can do. There's a lot of advice out there. There's a lot of jet lag apps and so forth. And the reality is that you need to sort of take care of things. You don't want to enter a plane very sleep deprived. You want to make sure you don't have a sort of sleep deficit, because you're only going to make it worse by flying. Drinking lots of alcohol, may be fun on a plane, but it doesn't help you sleep, as we sort of talked about before. Your best bet is to really set your time to where you're going. If you're going from Sydney to London, and you try and sleep if we can, closer to the London time, because most of the flights get in early in the morning, and that's the strategy. But you know, flying is not great for sleep. You know, and again, you asked me about medication before. I used to take something when I wanted to fly, but these days I take one of these newer medications, the orexin antagonist, because at least when I get to London or wherever, I don't feel so bad.
Thank you. Did you want to comment, Gerard?
Yeah, I was going to say the pilots have a saying, flying east to west is best because you delay your sleep. When we go away from Australia and go to overseas, it's usually not too bad. But when we come back to Australia, it's harder because you're having to advance your sleep. I find when you go overseas, the best thing to do is to, if you're going to be there for a while, to immediately go outside and not go to bed if you get there early in the morning. Because a lot of people tend to get there and go straight to bed, and even though it's daytime, but if you stay up all day and manage to make it to about 8 o'clock at night time, you adapt a lot quicker. And the same on the way back. You know, if you get in early in the morning, you feel like going home to sleep, but I usually go home and sort out my washing and try and stay up till about 7 or 8 o'clock at night time at least. And then you tend to only take a few days to adapt back. Because I've had patients that have gone overseas and come back and they've still had jet lag 2 months later because they're giving into sleeping on the English, timeline in Australia during the day because they're retired, So melatonin can be helpful to help you sleep at the new time. Some people will take melatonin. I've never taken it myself, but a lot of my colleagues swear by a dose of melatonin at the local time in England or Germany when it's bedtime to help promote sleep. And just getting back to what we're talking about before, napping, I like to sometimes call napping palliative napping, where you just have short naps to help you rather than long naps that might interfere with your nighttime sleep. And it'd be the case in jet lag as well. If you feel not well, have a nap, but try make it not too long.
That's amazing. Look, Ron, just before I come to Lena for another question from the audience, something's been on the back of my mind. At the opening of our session today, we had a concentration on the need for, or the value of weight loss in assisting in sleep. But I thought there's bound to be some thin people tonight, older people, because you know how sometimes we get thinner as we age, particularly as we get into that greater age. We had quite a lot of people over 80 watching us. Is there sometimes sleep that isn't associated with weight? So sleep difficulties?
Well, I mean, if you're talking about sleep apnea, I said 70% of people have it because of it being overweight, but then there's a lot of people also have the facial issues that Michelle brought up, and they're also going to get sleep apnea. And sometimes it's a combination of both. And that's why it's impossible always to say, if you lose 20 kilos, you're going to lose this much sleep apnea and you're going to be that much more awake, because it does vary according to causation. But the other thing that you've got to understand with aging, I guess, is that sometimes it's too dangerous to be too thin as you get older, particularly if you lose a lot of muscle. And, that's why I'm always happy to see people, in their 80s, doing exercise in the park opposite my house, because that's important, So, there's a danger as you get older of too much thinness, if you know what I mean.
Yep, I do. Thank you. Lena, another question from our audience, please.
So we have a question on snoring. Is it generally worse when lying on one's back compared to lying on the side?
To Ron, and then I might come to you, Michelle, please.
Yeah, so that's true. Because of the balance of forces in the airway, and airway is more collapsible when you're lying on your back. And there are devices that we use for the treatment of people who have just predominantly sleep apnea on their back that actually are designed to briefly wake people up. Not, like in a way that they don't wake fully up, but they change body position. Because we all change position many times during the night. I mean, Gerard talked about, serious awakenings, but we have multiple little unrecognisable awakenings when we change body position. So if we can get people to sleep on their side by this sort of giving a bit of a vibratory stimulus to the neck or to the sternum, so it can. The problem is people have trouble using these for long periods of time, but they do work. It's just, getting back to word that Michelle used, adherence.
And what do they look like? What, when you say it's something to keep you not on your back, what?
Well, they're just like a band around your chest or even around your neck, where there's a little device that kind of vibrates if you're on your back and for any length of time, and then that your natural thing is to actually go onto your side.
Yes.
So there are sort of multiple. You don't notice it, it's not like it's electric shock or anything like that. It's just a soft vibration against the bone, and they work. There's a lot of studies to show that they work. It's just people using it long term, you don't know. And also, not everyone is just on their back. Obviously, they sometimes they're on their side. I mean, sleep apnea can be quite variable. Like it doesn't always be. It's not the same every night. And of course, alcohol makes sleep apnea worse. So if you drink, that also adds to the variability.
Did you want to comment, Michelle, on that question?
Thank you. So that can represent a very challenging case. Snoring while resting or sleeping in the back position. So you might meet a male patient who's had a shoulder injury, shoulder reconstruction, back injury, back surgery, taking analgesics, painkillers, and can only sleep on the back. So the persistent noise, some patients might do better with CPAP if the noise is persistent. But depending on the type of apnea, as per the sleep study, the patient can sometimes do well with a mandibular advancement device, provided there is a lip seal and the ability to achieve mouth closure. So some of the devices will assist the patient to keep the mouth closed. What you don't want is mandibular advancement device and the mouth is opening. So that can happen if it is a poorly selected appliance.
Okay, and that adjustment process that you referred to at the beginning. Thank you. I think we've got time for one, maybe two more questions. Let's go, Lena. Thank you.
So there is another question for Michelle to follow up on the subject of mandibular splint. Something called Snorix mouth, which is a mold that you can buy and then bite into it and adjust the lower part and push the lower jaw forward. Does this work as a mandibular splint?
Okay, so this is what we call over-the-counter appliance. It is non-customized. So the adherence of these devices is quite poor because the patient will experience the bulk, it's not retentive, it will fall out, and the jaw is aching because it's too thick and the muscles can't adapt. So they might use it for a couple of nights. Sometimes the patient will reappear at the clinic and say, look, I tried this thing, the noise came down, but I can't wear it long term. Please give me a customized device. And that's when we do digital scanning and it goes off to a proper Australian standards lab and it's constructed. So then the patient can have something that's durable and will last them maybe 7, 8, 9, 10 years. But this over-the-counter devices, many out there. Some I cannot justify the price for some of them. It's $300 or $400, but very rarely will you meet a patient who, yes, has got the setting correct and can wear it for an extended period.
Can I just ask, if a referral is made by a doctor to you, is it covered by Medicare or is it like other dentistry, you have to pay privately?
Okay, so I think that the World Health Organization last year created a policy on integrated oral health, speaking with primary care providers, general practitioners. We are trying harder to work together. And I think that there needs to be a big shift in policy in this country in providing this treatment on Medicare. Okay. To answer your question, no, there is no Medicare, but this is the treatment of a medical problem by a dentist. It's simply by virtue of my hands belonging to the dentist, but I'm treating a medical problem. So there's no Medicare, but I do hope that there's going to be a shift in this. We've got, I think it's, how many million over 50s in Australia do we have?
A lot.
So it would really assist people if we could improve productivity and well-being.
Could I come to you, Ron Grunstein, on that issue? Is there any movement to see if there can be some Medicare coverage for this that you're aware of?
I mean, there are mechanisms, and I think better say, Michelle, that there's some private health funds that do cover part of the cost or so forth, but not. I mean, it's a really tough gig, to try and get past the different sort of regulatory, the government doesn't like to part with its money.
Yeah.
Maybe in Victoria they like to part it for Commonwealth Games, but it's a different sort of issue. I agree with Michelle. I think that if you had guidelines and agreed standards, there should be support for these devices, as there should be support. I argue with people all the time, say medications for obesity, you are going to save the government money in the long run. And that'll be an argument that's going to be had over the next 5 years.
I just, if I could just quickly say, as some of the audience will know, I had a head and neck cancer 10 years ago, and I had a lot of radiation, and many people have a lifelong limited saliva, and you need saliva for healthy teeth. And yet the access to publicly funded medical care for head and neck cancer patients, even though the problems are directly related to the treatment, is extremely limited. And it's just another example of that failure to include some important dental issues in Medicare. One quick question, Lena. Let's have one more before I close our session. And thank you so much to all our panel. It's been very interesting. Thanks, Lena. I think Lena. Is it possible, Nat, for you to unmute Lena? For some reason, thank you very much.
Now I'm unmuted. Thank you. Well, there is one question that I always wondered about. Does avoiding cheese last thing at night help you sleep better? Avoiding cheese?
Goodness me, Professor Grunstein.
What sort of cheese? Look, I mean, that's an interesting. It's just that there's a lot of studies about food, different foods and their effects on sleep, and you hear all that sort of thing. The quality of those studies are often poor. I'd open it up to my colleagues here, but I don't recall anyone, what's the effect of camembert on sleep and that sort of stuff. Because there's a lot of difference between sort of the chemicals in cheese, the natural chemicals sort of thing. So I don't know.
I've heard a couple of things. Some people say that if you eat a lot of cheese before you go to bed, you have nightmares and very bizarre and vivid dreams. And I think there might be a precursor in the cheese to serotonin. So I don't know, much research has been done on it. Maybe the Swiss should get into it because they're making cheese, or the Belgians, Belgian blue or whatever. Depends on the cheese, I guess, too.
I think there's a general point that you don't want to eat too much before you go to sleep. That's the reality. So forget about just cheese, just anything, alcohol, a steak, whatever.
Large pizza.
Large pizza, yeah.
No, so it's good. It's not good to go to bed with a full stomach.
No.
Okay.
You don't want to go to bed hungry, but you should eat, more, especially in the older audience, eat more like your grandchildren early.
Okay. Just a quick comment from you, Gerard. I can feel you vibrating.
Oh no, I was just scratching my head, but
okay.
I think Ron's point's great because a lot of people, obesity is a problem, and if you eat too late, you're storing most of the fat that's in the food rather than burning any of it during the daytime, like you would if you ate earlier. Most people tend to eat, 6 o'clock, 7 o'clock, which is probably okay. I know that culturally, some people, like I've had Sri Lankan neighbours, and they never have dinner until about 10:30 at night time. So there's cultural aspects to the whole thing as well about when people eat, which adds to the problem of obesity.
Well, just finally, because it is time for me to bring this to a close, but Ronna, could I just ask you one last thing while this cheese matter has been raised? Some people have warm milk, or there are some teas, herbal teas that they say can help. Is there any research done on that sort of assistance to sleep?
Look, I think most studies are neutral. People saw warm milk because it was rich in tryptophan, which is a serotonin precursor. people have done studies where they've given tryptophan as a sleeping medication, and they're pretty equivocal. I mean, to be honest, if there was a food that really, made people go to sleep, quickly, it'd be out there. But, companies like Nestle and Mars and all the big companies are always working on foods that they think will help sleep. So they often add, hops and it's got valerian, which is thought to have sleep-inducing properties to drinks and so forth. So, but hard evidence, I don't think there is.
Look, ladies and gentlemen, and everyone, on behalf of you, I'd really like to thank our panel. Dr. Lena Saffron, our general practitioner, who's been moderating your questions, Professor Ron Grunstein AM, Professor of Sleep Medicine, Professor Gerard Kennedy, a Professor of Psychology, and Dr. Michelle Donegan, our specialist dental sleep medicine person. I must say that's a whole new area for me, and it's been great to have you with us this evening. Thank you very much. This is deaf sign clapping, and so I'll clap you all. And I'd also very much like to remind you that you will receive an email after the session, everyone who's registered had, and there is a survey asking for feedback. There is planning occurring right now for the sessions in 2024, and they do really respond to your feedback. So please fill in the survey. Remember that this webinar is recorded and it will pop up on the Wolper Hospital website. If you look there under the community wellbeing sessions, you'll see it. And there's a whole backlog of panel discussions on a whole range of topics. And this is our last webinar for 2024. In the new year, there will be an announcement of a new lineup of webinars. If this is your first time, these used to be face-to-face in the eastern suburbs of Sydney, where Wolper Jewish Hospital is, but there was a vote taken after COVID when we went online to stay online. So there will be another program online next year. And also, I understand the development of a new Facebook page dealing with all of this as well. So can I just say, thinking of everyone at this time as things unfold in Israel and the Middle East, and thank you so much for joining us tonight, and thank you and farewell. This is my clapping. Bye-bye.